Tonya, I think we can call this panel to an end. Thank you. Thank you very much. And what I'm going to say fits in the middle of the arc that was drawn by the initial remarks of Lark Thomas, speaking about the importance of looking at trauma not only from a behavioral perspective, not only from a mental health perspective, but from a social perspective in terms of how it affects every facet of our lives as citizens and as individuals, and the way that Tonya described the very intimate roots of trauma and its ramifications across generations. Thank you. We know that, oops, how do I turn this next?
You have the wrong presentation up. It should be Alicia Lieberman's.
We know that trauma is an epidemic, and in particular that violence is an epidemic. And I'm going to be talking about violence as the most insidious, pervasive, and intractable form of trauma, because it is the vector through which other traumatic experiences come and visit people's lives. And violence begins at the beginning. It's very hard to bring this message and make service providers, parents, the public at large believe that babies and young children experience trauma and respond with traumatic stress to events that happen to them that are frightening, terrifying, and shatter the sense of expectable trust that adults can protect them. We know from cumulative evidence of studies that domestic violence during pregnancy has more damaging effects than medical conditions that are routinely screened for in OBGYN departments. And yet, OBGYN providers often avoid asking about domestic violence, although domestic violence is associated with placenta previa, premature delivery, increases in C-section, and also mortality of the baby and developmental problems in the baby, as well as infectious diseases after the baby is born. And domestic violence is one of the most powerful predictors of neglect and trauma in early childhood. But we also know that violence does not occur in discrete doses. It is epidemic, and it cuts across different forms of trauma at different settings. And we know that in the community, for example, a very high percentage of preschoolers and children in the birth to 5 age range are exposed to community violence, see and live weekly drive-by shootings, see dead people on the street, witness robberies, witness fights, and go home often to watch that violence be played out interpersonally. Preschoolers are much more likely to live in families when there is domestic violence than older children. And there is an overlap with community violence, domestic violence in child abuse, and the first 5 years of life are the most dangerous across the lifetime. Mortality as a result of maltreatment in the first year of life is highest than in the entire age range until age 18. And yet our systems are not geared to respond to trauma in infancy and early childhood, and our graduate schools, our medical schools are not training professionals to identify, ask about early trauma. Who is at highest risk? I think that it won't come as any surprise to you that children who are living in poverty, children from ethnic and racial minorities, young children, and children in single-parent families. And of course, all of these risks tend to cluster together. We also know that domestic violence and sexual abuse are very high predictors of other forms of trauma, including physical abuse, cumulative and repetitive physical abuse. So trauma is a very complex phenomenon. It cuts across at every single moment. The range from family to society and from parents to babies to preschoolers to adolescents to adults. And at every single moment of trauma, every aspect of the organism is affected: the biological, the emotional, the cognitive, and the interpersonal. And Tonya showed us through her own experience how people tended not to ask why. How come this happened? How come this presenting problem exists? One of the clusters of post-traumatic stress disorder is avoidance. It is the one, of course, that is the hardest to identify, because we know that it's hard to see avoidance. It's hard to see something that doesn't show itself. And yet, avoidance is contagious. And victims of trauma do not want to talk about the trauma for shame, for fear, for an effort at self-protection from being flooded by the dysregulated emotions, by the terror that comes with trauma. And the service provider then does not want to ask about trauma because ostensibly we are afraid of being tactless, intrusive, but really because we don't want to hear, and because we don't know what to do with it once we hear it. And so the importance of transcending avoidance, both as a form of treatment and as a form of training for practitioners in the mental health and in every aspect of intervention, is really of the highest importance. I'll give you a couple of examples. When I direct the Child Trauma Research Program. It's a trauma program for children. It's right in the name. So people tend to refer to us children who are traumatized. When we get a referral, the referring person says, this child witnessed domestic violence, or this child was physically abused, or this child was sexually abused. And these are children specifically in the birth to 5 age range. The majority of children referred to us are referred with one trauma. When we sit with the parents and ask, has this happened to your child? Has this happened to your child? Has this happened to your child? In 2 sessions of talking about this, we find that the vast majority, 70% of the children, have at least 4 traumatic events. And in the first 5 years of life, the average number of traumatic events that parents report to us in their children is 8 traumatic events. And yet, nobody knew among the referring people because there is a reluctance to ask. As a recent study published by Crasto and his team at Yale University found similarly that in a regular clinic, not a trauma clinic, 65% of the referrals were for behavioral problems in children, and only 13% of the referrals were because of traumatic events. They adopted a screening form that we developed in my program, Chandra Ghosh Ipen in my program developed it, that looks at traumatic stressors for young children. It turns out that 65% of those children had experienced at least one traumatic stressor. and at least 40% have had experienced 4 or more. So again, the question of asking why, asking how, asking about what is the experience of children that come to our services. And of course, we know that the more traumatic stressors, the higher the number of symptoms and the higher the likelihood of a diagnosis of traumatic stress. Now, it's not enough to ask about child trauma. When we ask the mothers, what about you? What has your life been like? Tell us your story. We find that more than 50% of the mothers have had at least 4 traumatic stressors, and the average number is 13. This is extremely important because when there is trauma in the parent, the ability to be a protective factor for the child is affected. And we know that mothers who are not able to remember and talk about their own abuse are much more likely, 12 times more likely, to abuse their own children. And so the importance of addressing relationships and focusing on the parent-child relationship as a form of treating trauma in 2 generations simultaneously is what I would like to convey to you. And that means supporting the child by supporting the parent and the parent-child relationship. The program, the treatment that we developed is called child-parent psychotherapy. We now have 6 randomized studies showing its efficacy. And the efficacy is across a variety of domains: attachment security, increases in IQ, decreases in PTSD, decreases in child behavioral problem, increased involvement of the mother in taking care of the child, and very importantly, in spite of the fact that we're not doing individual psychotherapy with the mothers scores in depression and PTSD decline significantly, and 6 months after termination of treatment, their scores continue to decline, so that they're feeling effective in protecting the child from trauma, in addressing the child's trauma, in feeling that they can be protective mothers. Their mental health improves, their depression decreases, their anxiety decreases, their PTSD increases. And so it's really important to think of how central to the mental health well-being of women their role as mothers is. Now, we support the caregiver to support the child. We want to support the provider to support the caregiver, to support the child. We're talking here about parallel processes and building capacity in the ability to listen to trauma, to withstand the burnout that happens when we are treating trauma on an ongoing basis is really the key to work effectively with traumatized families and their children. And we feel that what makes a dissemination model work is repeated face-to-face encounters, reflective supervision in terms of enabling the provider to speak about the difficulties in working with traumatized children and their families, in seeing the abuse, in doing home visits and seeing the hardship that these families encounter, and providing follow-up consultation after the initial training. And finally, it's really important to think, yes, there is such a thing as evidence-based, but what is really important is effectiveness in the community, adaptation to the specific needs of the populations that we work with, and engaging the continuum of care. And this is where the Trauma Justice Initiative holds so much promise. We are now applying child-parent psychotherapy in the OBGYN department, in pediatrics, in child welfare, in the judicial system. And I think that we as mental health providers need to come out of our mental health offices, come out of our playrooms, and go to the places where traumatized children and their families are found. Thank you very much.
Thank you, Alicia. Our next speaker will be Valerie Edwards.
Good afternoon. I just want to say thank you so much for listening. This is such an honor for me to be able to address you and talk to you about the work that I've been involved with really for about the last 15 years, working on the Adverse Childhood Experiences study. Now, where's the little, here it is. Okay.